So yes, I'm a biostatistician by training. So I'm going to give this is my nonlinear overview. I'm going to try to talk about my own journey and how it's informed the work that I do. But my journey has been very nonlinear. But I think sometimes it's important to understand one's journey as far as where they were and how they've gotten to where they are and why they're passionate about what they do. So I was born and raised in Bryn Mawr, Pennsylvania. Somebody told me that Dr. Outlaw is, where's it? Ah! Okay, so I haven't seen Dr. Outlaw since I was a child. But yeah, it's been a while. But in fact, it was her family at Haverford College, and I'm from Bryn Mawr, which is by Bryn Mawr College, where through her teachings, I learned a lot about the culture across the African diaspora, her and her husband. But yeah, I'm from a small town outside of Philly, which is also known as part of the Main Line. So I thought that I was going to be an interpreter for the United Nations. You know, when you take those AP courses or whatever, the only one that I got a 5 on was in Spanish language. So I assumed that my calling was to be an interpreter for the United Nations, so I went to Swarthmore to be a Spanish major and an interpreter. I came out a chemistry major with a Spanish minor. That had to do more so because my father just kept asking, okay, so you speak Spanish, what else are you doing? Maybe I didn't get the encouragement that I needed, but I also always loved science. And I thought that I was going to do more around pharmaceuticals and thinking that that's what I should do to kind of help find that cure that was going to treat a lot of the ailments that I was seeing, even in a suburban community among populations of color, for example, who also still had access to care. But while I was working long nights in a company for Johnson & Johnson with like 3 HPLCs at once, and all of them would fail, the mobile phase would run out. And I was working a night shift. I realized that I had time to think about my calling. And I started questioning why I was seeing many in my community who do have access to care still suffer from premature morbidity and mortality. And I started asking questions about how do we embody things like racism? How do we embody this world around us that informs our health? And so I decided that I wasn't going to be an interpreter for the United Nations. I wasn't going to be a chemist, that I was going to be a social scientist. So I went off to Columbia, to the Mailman School of Public Health, to the Department of Socio-Medical Sciences to get my master's. But it was in my master's program where I started learning the vernacular of structural determinants of health, and I was surrounded by anthropologists and sociologists. This wasn't a part of my chemistry curriculum. But it was there in my master's program where I took my first statistics class. So you would have thought that as a chemistry major I would have taken statistics, but I didn't. I took multivariable calculus, I took linear algebra, I took all of these things but had never taken a statistics class. So it's in my master's program where I took one statistics class and I liked it, and another, and another, and I started thinking, wait, statistics is a tool to help us answer questions about how we're embodying the world. How we're embodying social structures and how they impact our health. And so that led me to getting my doctoral degree in biostatistics at Columbia. I did try to leave Columbia, but I got rejected by the other program, so I stayed and they kept me. But that's how I went through this whole trajectory of becoming a biostatistician. I say all this to say that while I was in my master's program, it's social scientists, it's anthropologists, there's diversity everywhere, everywhere. I mean, you could think of every possible group you could think of, racial ethnic minority, LGBTQ, everybody was represented. And then here I go into biostatistics, where the culture was very different. And here I was looking at it. In fact, one of the professors told me, you know, you're one of the first people of color to, you know, Black people to be a part of this program. Now think of all the pressure you have, right? And then to hear that, I'm like, I don't want to mess up, because I'm going to mess it up for everybody behind me. Now that's a ridiculous thing, but sometimes we think that way. And it was different. I didn't have, they were saying study for the qualifiers, but I didn't really know what a qualifying exam was. There were a lot of study groups, but I was kind of outside of the cultural norm, and so I wasn't always invited. And honestly, I failed my qualifiers the first time. That's how I learned what a qualifier was. Thankfully, I passed the second time. But I really, I felt alone. And sometimes when you feel alone, you really question your scientific identity. You question your sense of belonging. When you question your scientific identity, then you're questioning whether or not you would ever make a valuable contribution to the field. And if you think that you would never make a valuable contribution to the field, you kind of say, why bother? And perhaps what I was feeling, I didn't know the stats then. But the reality is what I was feeling was probably what a lot of folk were feeling in our field, in terms of if we think about the underrepresentation of people of color in our field. And in fact, this is data going from 2011 to 2022. So to some extent, we still need to do more work in the field. But the data, I guess, kind of highlights maybe the isolation I may have felt at the time. And for those who are like unfamiliar with a sense of belonging, I feel that Kirsten Perez said this very well, in that belonging gives name to the growing tightness between my shoulders as I approach campus each day. Meharry, maybe students don't feel this way, but sometimes outside of the nurturing environment that you probably have here, we do feel this way. Arranging my mental armor to defend my own sense of worth. Belonging recognizes how many of us readjust our clothes and our speech to negotiate the unspoken norms of our profession, where brash confidence is confused for competence, and where humility, uncertainty, and collective questioning are seen as failings. That's how I felt. But somehow, my personal challenges in terms of understanding whether I belonged in this field of biostatistics propelled me to think about how I might be able to contribute to making someone else feel like they belong, those coming behind me. And so I think while working on a statistical inference problem set, which is very easy to procrastinate when you have 3 questions and you can't even figure out part A of the first question, but it propelled me to work with a couple students at the time and just go to the chair and say, hey, can we start a summer program? We didn't think the chair would say yes, but he did. He said, you know, we definitely been thinking about the lack of diversity in the field, but no one's really come to us to think about how to fix it. And since you want to fix it, go ahead. And they gave us like some resources, and we started what's called the Best Diversity Program. This was in 2008. We started it with internal resources, and the idea was to just expose underrepresented undergraduates, those from economically disadvantaged backgrounds, et cetera, to biostatistics and its applications in public health. We piloted it with city college students, maybe like 8 city college students. By the next year, the program got funding from the NIH. The program's still going on to this day. I didn't imagine the impact that it would have. Within 10 years of the program existing, there were 110 undergraduates who had participated in the Best Diversity program, and of those who had graduated from their undergrad program, 75% of them went on to grad school. They didn't all become biostatisticians, but they went on to grad school. I think in that, maybe there was a moment where I started realizing that, okay, maybe there is something I'm contributing to in my field. And I think just that experience just propelled me to doing service and scholarly work, just thinking about representation and advancement in my field. I'm not gonna read all these things, but just some examples. But even having conversations at stats conferences, questioning, what is it about our field that is not inclusive? What is it about our field that folk aren't getting exposed to and wanting to pursue it? And it was in 2017 when I participated in a panel at the Joint Statistical Meetings in implicit bias in the profession of statistics that I met Dr. Amanda Goldbeck, who came to me a few years later and said, I'm writing this book on leadership and statistics and data science. And I was like, she asked me, would I write something about power and privilege? I said, that's a big topic. But she allowed me to contribute to the discourse in our field around reshaping the opportunity structure for equitable leadership in statistics and data science. And to some extent, I did have to go back to the social scientists and cultural scholars of our time. I had to read Audre Lorde. I had to read all of these folk to then understand how we need to improve the opportunity structure in our field. But I'm talking about all of these challenges within the field of biostatistics, but then here I'm existing in academic medicine. And the same things that I'm seeing in my field, I'm seeing as a whole in academic medicine. And so in 2020, I launched the Center for Scientific Diversity at Mount Sinai. And basically, it really is focused on inclusive excellence and DEIA, and it's guided by 3 foundational pillars: rigorous multidisciplinary research, training and enrichment, and advocacy, where we focus on systemic barriers to the recruitment, retention, advancement of underrepresented trainees and faculty in the biomedical research workforce. But we approach it as a science, right? So we're trying to build an empirical evidence base for theory-driven, sustainable solutions. So we approach changing the demographic landscape and reconfiguring opportunity structures of the biomedical research workforce, like I said, as a science. And it requires a paradigm shift. For example, all of the initiatives we put out there to increase diversity, how rigorously do we test how effective these things are, right? So we need to actually think of this as a science and then also give value and credit to those who are doing this work and understand the importance of it, because of course, this is necessary. Diversifying the field is necessary for advancing science and healthcare innovation. One of the major successes to date is the NIH FIRST program at Mount Sinai. And this is, we received this grant. I was surprised when we received it because we had like 2 months to write this grant. But it basically is, we got funded to do a cluster cohort hiring initiative at Mount Sinai. And in fact, Dr. Bob Wright, Dr. Roz Wright, Dr. Keisha Carroll, there's a whole host of folk who, while I serve as contact PI, across the institution who are making this possible. And the idea is thinking about how do we accelerate inclusive excellence at our institution and beyond, and leverage existing institutional commitment to anti-racism in DEIA to recruit, cluster, hire, retain, and advance 12 faculty committed to DEIA, with emphasis on those who are underrepresented in science and medicine across 4 interdisciplinary clusters. And I'm happy to tell you more about it, the conference. And we're still recruiting, so hey, check it out. Okay. But generally, this is exactly what I'm talking about, where we're doing science here. We're testing a hypothesis that a cohort and cluster design model of faculty hiring, in addition to getting comprehensive, or I should say competitive startup, and a comprehensive plan for mentorship, sponsorship, and professional development in an institution implementing evidence-based practices to achieve inclusive excellence and having rigorous and iterative multi-level mixed method evaluation. You kicking me off soon? 2 minutes, okay. Yields increased research success and reduces isolation, increases sense of belonging, and creates a sustainable transformation of institutional culture. So this is what we're testing. And to date, we've hired amazingly brilliant faculty, and just so happy about this. We have a few more to go. Like I said, we're still recruiting. But it's just amazing to see. I want to continue to see them thrive. So in 1.5 minutes, I'm going to tell you also, just briefly, about, you see kind of my passion for DEIA and inclusive excellence, but also I think as a biostatistician at a certain point in my career, I had this like philosophical dilemma where I started questioning, a lot of researchers would come to me and say, we want to look at racial differences in X. And I kept hearing that over and over and over and over. And I kept questioning why we always start and end with race. Like we observe a racial ethnic difference, and then after adjustment for numerous covariates, differences remain. And then we say further research is needed. And we just do that cycle over and over and over and over, right? And so we describe racial ethnic differences often, but identification of effective targets for intervention is less frequent, right? We just don't see that as much. And I kept searching the literature for guidance from statisticians, and non-statisticians about how we should be more optimally operationalizing race. Like, I needed to fundamentally change my approach. You would think that as an African-American biostatistician that I would have some different approach, but I'm trained in the ivory towers, right? So I realized I'm replicating something that I'm taught, but I wanted to really think more about causal pathways in health disparities research. And of course, because all of you have taken stats, good research always starts by stating your question, right? We have some motivating example. Is there a racial ethnic difference in the risk of some disease? I'm going to go quickly. We state our null and alternative hypotheses, where the null might be that the risk of disease in blacks, for example, is equivalent to the risk of disease in whites, and everybody knows what the alternative is, that the risk differs. Right? We power our study to detect a clinically meaningful difference given our hypotheses. And then we sample from the population, collect data, conduct an appropriate analysis. All of this is like that, right? And then we say, we have sufficient evidence to suggest that the risk of disease differs between black and whites with some magnitude at least as big as delta. Do we get closer to fixing the problem? Well, Kaufman and Cooper, check out their work. Kaufman is a statistician, Cooper, epidemiologist. They were writing in 1995. They said no. They said, when we set out to measure phenotypic traits in blacks and whites and find them different, we conclude that blacks are different because they are black. Maybe unintentionally, for well-intentioned researchers, this conclusion reinforces the belief that biology is consistent with the social definition of race, namely distinctions on the basis of skin color. And so they tried to think, what if we think of some other axis? What about, I don't know, like blood type? And they would say that that's kind of crazy if we were to look at this alternate classification scheme and determine that they're different. Most people would not think that it's causal. And so they just said something that's gangsta, and then I'll go quickly through the rest. They said to believe that skin color has a unique association to outcomes ranging from IQ to blood pressure to prostate cancer by sheer chance is questionable, if not preposterous, proposition. Somehow this never made it into my stats curriculum. And they went on to coin this concept of circularity, where our efforts to understand social factors have the effect of emphasizing racial differences. So we get stuck in this circular slump that gets us no closer to fixing the problem. And fine, if you don't want to believe the statisticians, we'll ask an evolutionary biologist like Templeton, who said that humans are an amazingly diverse species, but this diversity is not due to a finite number of subtypes or races. Rather, the vast majority of human genetic diversity reflects local adaptations and most of all, our individual uniqueness. So we have to change how we're taught. And you know, I decided, okay, maybe if you don't want to stick with Kaufman and Cooper or Templeton, you can talk to Holland, who was a statistician for the Educational Testing Service, who said that the race effect that we measure does not have any causal interpretation. Causes should be experiences individuals undergo, not attributes they possess. Causal variables must reflect the possibility of manipulation. And while race is not a causal variable, it can play a crucial role in causal studies for a few reasons. Maybe for descriptive reasons, but he says the attribution of cause to race as the predictor of these differences to him was the most casual of causal talk and does not lead to useful action. Ascribing a causal role to race does not get us closer to change. We should address racism. We should address the environmental aspects. We should address all of those things, and then sometimes try to understand that under certain conditions, these things don't always play out the same for different groups. Like education, it's good for health. But I imagine if we were to look at race as an effect modifier here, we might find that it doesn't play out as well for certain groups as others. Maybe because we have to think about quality of education. Maybe we have to think about policies informing the type of education that certain communities get and the impact of those things. But anyway, you can read more, you can check out some examples here. But I just want to say that as a biostatistician who once questioned my own scientific identity and sense of belonging, I approach promoting and sustaining DEIA and inclusive excellence in my field and the biomedical research workforce more broadly with the same methodological rigor with which I tackle health inequities and in any other complex biomedical challenge. These efforts are synergistic in nature. And the mathematical, statistical data sciences are most optimally positioned to advance healthcare equity and innovation when our efforts to increase methodologic ingenuity are coupled with service and scholarly endeavors to diversify the biomedical research workforce, promote sustainable culture change, and ethically engage our communities. Thank you.